So much, Professor Glakopoulos, for this introduction. Let me share my screen. Before starting my presentation, I would like also to thank the President of this Congress, Professor Vassilios Kotsis, for this honorable invitation. In this lecture, I have been invited to discuss the management of hypertension in patients with advanced chronic kidney disease. And here is a brief introduction. Hypertension and chronic kidney disease are two pathophysiological states with a bidirectional interrelationship. The persistently high levels of blood pressure can accelerate the progression of chronic kidney disease. However, the progressive decline in the levels of eGFR can conversely act as a barrier to the achievement of an adequate blood pressure control. And here you can see that there are several mechanisms involved in the pathogenesis of hypertension in the chronic kidney disease setting. This is a combined analysis of 17 cohort studies involving approximately 35,000 individuals with hypertension and chronic kidney disease. As you can see, hypertension in the CKD population remains often inadequately controlled, despite the extensive use of multiple blood pressure lowering medications. These observational data provide a first signal that hypertension in chronic kidney disease is often resistant to the prescribed antihypertensive therapy. And this is a global meta-analysis of 91 studies involving a total of 3.2 million people with drug-treated hypertension. This meta-analysis showed that in the general hypertensive population, the prevalence of true resistant hypertension is approximately 10.3%. As compared with the general hypertensive population, the prevalence, the burden of resistant hypertension is twofold to threefold higher among patients with more advanced chronic kidney disease. And this table provides a summary of all recently released guidelines for the assessment and the management of hypertension in the CKD population. As you can see, most of the recently released guidelines recommend a tight blood pressure target, recommend that blood pressure should be intensively controlled below the threshold of 130 millimeters of mercury systolic and 80 millimeters of mercury diastolic. All guidelines consistently recommend that the assessment of hypertension should be based on a standardized blood pressure measurement methodology in the office environment. For the treatment of hypertension, all these guidelines consistently recommend the use of an ACE inhibitor or an ARB as first-line antihypertensive therapy. And for those with resistant hypertension, the guidelines recommend the use of the steroidal mineralocorticoid receptor antagonist spironolactone as the preferred fourth-line antihypertensive therapy. In the following sections of my lecture, I will discuss some particular aspects that are of clinical relevance for the management of hypertension in the subgroup of high-risk patients with more advanced chronic kidney disease. And the first issue is the continuation versus the discontinuation of RAS inhibitor therapy in these high-risk patients. This table shows that there are several landmark trials that have demonstrated the kidney protective effect of RAS blockade in patients with proteinuric chronic kidney disease. All these trials have provided evidence that as compared with placebo or as compared with active treatment with other antihypertensive drug classes, ACE inhibitors or ARBs were superior in retarding the progression of chronic kidney disease in patients who had CKD and severely increased albuminuria. Secondary analysis of these landmark trials also showed cardioprotective benefits with the use of RAS inhibitors, mainly a reduction in the risk of heart failure hospitalization. However, there are some recent large-scale observational studies showing that in patients with advanced and progressive CKD, those with an eGFR below 30, that the discontinuation of ACEs or ARBs may be associated with a lower absolute risk of initiating kidney replacement therapy. However, these observational data should be interpreted with caution. We all know that observational studies cannot demonstrate direct cause and effect risk associations. So we have more direct evidence from a recently published randomized control trial, the STOP ACE trial, that was published in New England Journal of Medicine in 2022. In this open-label RCT, 411 patients with advanced and progressive chronic kidney disease, eGFR below 30, were randomized either to continue or to discontinue RAS inhibitor therapy. The median duration of follow-up was 3 years. The pre-specified primary efficacy outcome was defined as the between-group difference in the mean levels of eGFR at 3 years of follow-up. Here you can see the baseline characteristics of study participants enrolled in the STOP ACE trial. This trial truly included patients who had advanced chronic kidney disease. The median levels of eGFR were 18 ml per minute in both study arms at trial initiation. The vast majority of these patients had severely increased albuminuria. With respect to the primary efficacy endpoint, at 3 years of follow-up, the least squares mean eGFR in the discontinuation group was 12.6 versus 13.3 in the continuation group. This small between-group difference of 0.7 ml per minute was not statistically significant. However, this difference was still in favor of patients who were randomly assigned to continue therapy with an ACE inhibitor or an ARB. Furthermore, as compared with the continuation, the discontinuation of RAS inhibitor therapy was associated with a non-significant increase of 28% in the risk of developing end-stage kidney disease or initiating kidney replacement therapy. Therefore, these stronger clinical trial data indicate that in patients with advanced and progressive chronic kidney disease, the discontinuation of ACEs or ARBs is not an effective intervention to delay the initiation of kidney replacement therapy. Another important issue is the enablement of the more persistent use of spironolactone for the treatment of resistant hypertension in this high-risk patient population. The Pathway 2 trial was a trial that established the blood pressure lowering efficacy of spironolactone in patients with resistant hypertension. This trial showed that as compared with placebo or as compared with active treatment with doxazosine or bisoprolol, spironolactone was superior in reducing the levels of home systolic blood pressure in a large group of patients who had apparent treatment-resistant hypertension over 12 weeks of follow-up. However, hyperkalemia acts as a barrier and restricts the broader utilization of spironolactone in patients with more advanced chronic kidney disease. The international guidelines discourage the use of spironolactone when the levels of eGFR are lower than 45 or when the pre-treatment level potassium are higher than 4.5 millimole per liter. So can we use the newer therapies that bind potassium in the gut to mitigate the risk of hyperkalemia in order to enable the more persistent use of spironolactone for the treatment of resistant hypertension in patients with advanced chronic kidney disease. This research question was investigated in the AMBER trial. In this phase 2b trial, 295 patients with uncontrolled resistant hypertension and stage 3b or stage 4 CKD were randomly assigned to receive double-blind treatment either with placebo or with the potassium binder patiromer. All these patients received open-label add-on treatment with spironolactone at an initial dose of 25 milligrams per day and their baseline blood pressure-lowering medications. Over 12 weeks of follow-up, as compared with placebo, the potassium binder patiromer mitigated the risk of hyperkalemia and enabled 20% more patients to tolerate and maintain on spironolactone treatment. The enablement of the more persistent use of spironolactone was also accompanied by a clinically meaningful reduction of 11 or 12 millimeters of mercury in the levels of unattended automated office systolic blood pressure. The subsequent Diamond trial that was conducted in patients with heart failure with reduced ejection fraction provided additional evidence that the potassium binder patiromer can optimize the blockade of the renin-angiotensin-aldosterone system in patients with HFrEF. However, this trial was prematurely terminated. The primary efficacy outcome of this trial was reappraised, and therefore we don't have a clear answer on whether the patiromer-enabled optimization of RAS blockade is translated into a long-term improvement in heart cardiovascular outcomes in high-risk patients, such as those with HFrEF. Another important issue is the optimal use of diuretics in patients with advanced chronic kidney disease. There is an established belief that thiazide diuretics or thiazide-like diuretics are less effective or are ineffective when the levels of eGFR fall below the threshold of 30. Therefore, all the past guidelines consistently recommend the discontinuation of thiazide or thiazide-like diuretics and recommend the use of a more potent loop diuretic in patients with stage 4 chronic kidney disease. In 2021, there is a landmark trial that investigated the blood pressure lowering efficacy of the thiazide-like diuretic chlorthalidone in patients with stage 4 chronic kidney disease and uncontrolled hypertension. In this trial, 160 patients were randomized in a 1-to-1 ratio either to receive double-blind treatment with placebo or active treatment with chlorthalidone at an initial dose of 12.5 milligrams per day. The dose of the treatment was progressively titrated up to a maximal dose of 50 milligrams once daily over 4-week intervals with the guidance of monthly monitor home systolic blood pressure. Here you can see the baseline characteristics of the study participants, truly patients with advanced chronic kidney disease were included in the CLIC trial. And here is the primary efficacy endpoint at 12 weeks of follow-up as compared with placebo. Chlorthalidone provoked a reduction of 10.5 millimeters of mercury in the levels of 24-hour ambulatory systolic blood pressure. In a subgroup of 114 patients who had apparent treatment-resistant hypertension at baseline, the placebo-subtracted reduction in the levels of 24-hour systolic blood pressure that was provoked by chlorthalidone was 13.9 millimeters of mercury. This potent blood pressure lowering effect was also accompanied by a significant improvement in albuminuria. as compared with placebo, chlorthalidone reduced the levels of UACR by 50%. These are preliminary evidence that chlorthalidone may also exert cardioprotective and kidney protective effects in patients with advanced chronic kidney disease and poorly controlled hypertension. Based on this clinical trial evidence, chlorthalidone is now recommended by the European guidelines as the preferred fourth-line therapy for the treatment of resistant hypertension in patients with advanced stage 4 chronic kidney disease. However, the use of chlorthalidone in daily clinical practice should be sensible and with careful monitoring of our patients for the prevention of adverse events. Over the course of the CLIC trial, a series of adverse events such as hypokalemia, hyponatremia, hypomagnesemia, hyperglycemia, hyperuricemia, acute and reversible elevation in the levels of serum creatinine occurred more commonly in the chlorthalidone group than in the placebo group. These adverse events occurred more commonly in patients who were receiving concomitant treatment with a loop diuretic. Therefore, the use of chlorthalidone requires close monitoring of the levels of blood pressure, of the levels of kidney function, and close monitoring of the serum electrolytes for the prevention of these serious adverse events. And the last part of my lecture is a look at the future. What does the future hold? Will we have additional effective therapies for the management of hypertension in patients with more advanced chronic kidney disease? In the previous lecture, we have seen data for the non-steroidal MRA finerenone. There are also some other agents that belong to this novel drug class that are currently under clinical investigation. One of these agents is the KBB 5074, now known as ocedurenone. This agent is being developed for the management of hypertension in advanced chronic kidney disease. There is a pilot randomized control trial that was published in Hypertension, the BLOCK-CKD trial. 162 patients with stage 3B or stage 4 chronic kidney disease and uncontrolled hypertension were randomly assigned to receive placebo or active treatment with ocedurenone at 2 different doses. The duration of follow-up in this trial was 84 days. Here you can see the baseline characteristics of study participants. The mean levels of eGFR at randomization were 31.6 ml per minute. The vast majority of these patients were being prescribed above 3 blood pressure lowering medications before the randomization. And at over a follow-up period of 84 weeks, as compared with placebo, the low dose of ocedurenone provoked a placebo-subtracted reduction of 7 millimeters of mercury in the levels of unattended automated office systolic blood pressure. As compared with placebo, the higher dose of ocedurenone provoked a higher reduction of 10.2 millimeters of mercury in the levels of office systolic blood pressure. The risk of hyperkalemia was not so high. Severe hyperkalemic events were not observed over the course of the BLOCK-CKD trial. The incidence of mild to moderate hyperkalemia did not significantly differ between the active treatment and the placebo groups. Hopefully, perhaps in the recent future, we will have additional therapies that belong to the novel class of non-steroidal MRAs that will offer an effective therapy for resistant hypertension with less severe hyperkalemia. Thank you so much for your attention.